Welcome to this edition of the Perspectives in Inflammation podcast, a series brought to you by the CSF, which shines a spotlight onto experts in the field of inflammation. My name is Professor Kevin Winthrop from Oregon Health and Science University in Portland, Oregon, and with me is my good friend, fellow CSF Steering Committee member, Professor Maurizio Cutolo from the University of Genoa, Italy. Welcome, Maurizio.
Thank you.
Ciao.
Ciao.
So we'll start the interview, I think, just asking a bit about your background and where you're from and what got you interested into the field of rheumatology. Why rheumatology, Maurizio?
Well, this is a very nice question. But I think that I start from student to be attracted by rheumatoid arthritis. By rheumatoid arthritis, one of the diseases, but generally by rheumatology, because at that time when I was fellow, many years ago, many decades ago, the concept of arthritis was a little confused. Everything was arthritis. Not like now that we distinguish very well. And so I started to be attracted by the problem of arthritis. And in my center at the University of Genoa, at Naples, at that time I was in Naples as a student, there was no service of rheumatology. So the chief of the unit said, when you will be degraded, you must become postgraduate in rheumatology, and we check where is the best. So I moved to Genoa in the center of rheumatology, and there I had quite good professors, and I learned how much is large the field of rheumatology. It's considered 200 diseases. So I at the beginning, I was still confused, honestly. And but it was moving at that time the interest for new biomarkers, interest from new dedicated therapies. So I started to understand that there was a lot of space for research and translational research.
Yeah, sure.
Yeah. So I was fascinated by, of course, the clinical implication of immune system activation. And because then we learn that everything is in some way driven by the immunological concept, from the biomarkers, as you test, to the therapies and etiology, physiopathology, and so on. So this was my beginning. Then I developed a much more detailed interest 25 years ago, thanks to my frequent coming in the United States. And this field was neuroendocrine immunology. So the complex network between the nervous system, the immune system, and the endocrine system.
That sounds even more confusing.
So I met the really, really important expert, that's George Cruzos, George Wilder, and they introduced me in this field, and I was fascinated. So we started to study, for example, the presence of sex hormone receptor macrophages in the cytosynovial tissue. One of this important aspect to try to link why female, for example, have an easier autoimmune rheumatic disease compared to male.
Sure, yeah.
Which is the role of pregnancy, why some improve and not. So this is still fascinating. And this was the reason at the beginning. Then I expanded slowly my interest, but the main focus was neuroendocrine immunology and translational and practical issues. And one of these we will discuss is the circadian rhythm.
Now, did you work in the United States for a while?
Yes, I spent wonderful time at NYU with Jerry Weissman and Stephen Abramson and Bruce Kronstein.
Yeah.
And I was an international fellow at NYU. And here we had a major interest for some extracellular matrix protein like fibronectin and platelet aggregation. So was another field at the beginning, at the very beginning. I don't tell you what did here, but many years ago. And this was my introduction.
So this was your fellowship. Then you go back to Genoa.
Then I go back in Genoa. And Genoa is a older university, it's a nice university.
Yeah, tell me about your center there. What's it like, your practice and your research group in Genoa?
In Genoa, what we do in a few words. We have a lab. We are lucky because we have a lab for basic research, translational research, with some biologists. And we investigate from the beginning the role of a sex hormone on cell model, in vitro models, modulating especially macrophages. And so we saw how estrogen enhanced the production of cytokines from macrophages, testosterone the opposite. So it was quite stimulating, because it was the beginning to try then to see different treatment, how they interfere in this kind of models. Modulation of cytokines.
Yeah.
This was our interest. And macrophage, as you know, is the major effector, practical effector, in terms of pro-inflammatory cytokines, TNF-alpha, IL-1, 6. And so we started to study cytokines in vitro and then in humans, in the sera, in patient treated, and looking, for example, when you give steroids, how change in relation to the change of adrenal hormones.
Sure. So you have fellows, you have trainees, you have a lab.
Yeah.
Probably a large clinic where you
the
have
clinic is good.
Yeah.
The clinic is good in different levels. Works the hospital, inpatient, outpatient, and we have also a section of imaging.
Yeah.
It's very important. And looking at recently at the microcirculation, looking at the capillaries, because many diseases start with trouble for the microvessels, and so we try to combine this easy and safe imaging with in vitro culture of endothelial cells or circulating endothelial cells or monocytes, and looking fibrocyte, and looking if there is any relationship with the severity of the damage.
Okay. Yeah. You know, when I first met you, I was impressed by lots of things, but a lot of the similar interests. I mean, I always thought of you as someone very interested in the influence of estrogen or other sex hormones in terms of inflammatory disease. I have similar interests in infectious diseases. We see some of the same things where there's a differential between male and female, and based on certain hormones in terms of how someone can handle an infection or their risk for an infection. So it's a fascinating area. Are you still plowing ahead in that area?
We're still working. Now we are starting to study some modulation, very interesting, in microbiome.
Yeah.
Driven by sex hormones, because microbiome, immune system, and gut, they are important co-workers, and the hormones, the steroid hormones, gender hormones are even play a role.
Yeah, and they probably modulate the biome. Yeah, absolutely.
And you are epidemiologist, and you know how the sex ratio change for disease and age.
And age, it's fascinating.
Yeah.
What about circadian rhythm? Now, I know we want to talk about it. I was going to ask you, or just tell you, I actually have a problem with mine. I think I can't sleep anymore. So what should I do about it? Should I take melatonin or what? Tell me about the influence of circadian rhythm, and how does it influence inflammatory disease?
Oh, yes. Circadian rhythm, it's something that we hope will continue forever, because the earth twists.
Yeah.
Light, dark, light, darkness, and the hormones, our brain, our hormones follow the rhythm. You know very well the jet lag we have.
Yeah, that's the problem.
When you alter night worker shifter or other situation, when you alter this, you broken the circadian rhythm, you broken the endocrine function, or you alter the immune system. So at that time, many disease, many risks, in cardiovascular risk increase. Why? Because you have an alternance of hormones, melatonin with the darkness, cortisol with the light, and they drive during the night the immune surveillance against cancer, against crystals, against bacteria, virus.
Yeah.
So the fever you see in the night, or the gout in the night, is related to the overactivity of the immune system, inflammatory reaction in the night.
Yeah.
In the morning, something
goes away.
improves.
Yeah.
So to try to keep the circadian rhythm, it's fundamental. And the sleep is important as, can I say, facilitator of this rhythmicity. Sleep is important. You cannot lose the sleep. No. You pay a price.
You pay a price. Yeah.
So circadian rhythm have been the reason for the Nobel Prize in 2017, Nobel Prize for medicine. But it's a peripheral circadian rhythm, was discovered that each cell has inside proteins that organize for 24 hours the rhythm of the cells.
Right.
But we are discussing about the central circadian rhythm driven by the light and the darkness. It's fascinating. It's fascinating.
So So should I use melatonin? Does it work? Is it safe? I don't know much about melatonin other than everybody takes it. It's all over the shelf at the grocery store.
Yeah, this among the different functions of melatonin, there is the induction of the sleep. But together with prolactin, melatonin is a strong hormone that enhances the immune response. So at the beginning of the night, especially the cytokines like the NF-alpha-1, if there is a disease, concurrent disease, inflammatory disease, with melatonin, was published years ago in British Journal of Pharmacology in the nice study, and showed that the administration of melatonin induced an increase of inflammatory biomarkers. So it's not suggested in patients with inflammatory disease to take it, because the risk is to enhance the night inflammatory reaction. Better to avoid. In normal situation, no problem. No problem.
And does it induce sleep? Is it successful at doing that, do you think?
Yeah, it's induced.
Yeah. Okay.
It's one of the functions,
So I should take it.
Because this is very
Well, how do you modify circadian rhythms? I mean, what? I mean, that's a question, and I know you're looking into that and doing that with your research.
Yes.
Tell me about that.
Yes. You know that already we use a lot of drugs following the circadian rhythm. For example, when you treat hypertension, you never give it the night drugs. Why? Because during the night the blood pressure physiologically get down. The temperature of the body got down, because during the night you don't use calories. So the pressure is down. You need the drugs to reduce the blood pressure in the morning when you start the activities. And this is the same approach for the treatment of inflammatory reaction, to optimize, especially in chronic disease, when you have to administer, for example, glucocorticoids, cortisone, that is full of side effects. Is reduced, the side effects are reduced when you use low dose for a long time, but still interference on our brain in producing the endogenous. So the night is the moment our body produces cortisol. But in chronic diseases, we are not able anymore to produce the right amount to control the inflammation. That is the reason of exogenous replacement therapy with low dose of glucocorticoids. But there are a lot of studies. The first one published on Lancet. If you are able to concentrate this exogenous steroid during the night around 2, 3 o'clock, when you have, in any case, the endogenous rise, this is a little low dose in chronic disease, you get wonderful results, especially if you look at the dose you use. You
so
can
we're talking
reduce the dose.
2 milligrams, 3 milligrams, how low?
How low? You can use from 5 to 3. Over the time, there are people in maintenance, patients with 3 milligrams. This is the threshold. In this threshold, they survive very well, and they accept. And this, having some modified release drugs, even for other treatments, for example, in adrenal hypoplasia, you can really mimic the natural, because maybe some people forget that glucocorticoids are hormones, like insulin.
That's true.
So they have a different way to treat them, because are hormones. So you have to follow the physiological rhythm. Insulin, you cannot give insulin at any time when you want. My glycemia, I take insulin. No, wait a moment. There are some right moments to do that.
What's the risk of the low dose steroids? I mean, of course, I'm always looking at the risk, and there is risks of steroids with infection, even at fairly low doses. But these are pretty low. But is that something you consider, or? Sure.
We published together with the EULAR group for the study of low dose glucocorticoids several studies showing that the safest dosage is under 5. There is different consideration what means low dose for glucocorticoids. In the United States, less than 10. In Europe, less than 7.55. We should say that based on the studies, less than 5 is the most safe. Even for the risk of infections.
2.5 is better than 5 in terms of risk. Good. Well, are there any upcoming developments in this area we should look for? Presentations here at ACR or ongoing studies that you're
regarding
excited about?
circadian rhythms?
Yeah.
Yes, there are some studies again that are looking at the chrononutrition, because many disturbances like bulimia or anorexia are related to even to the wrong timing in the food. Yes, assumption.
Huh.
This alter the distribution of calories during the
Right.
day and alter also the immune system, of course, as a secondary effect. So it's suggested, based on evidence, that it should be kept during the day the fixed time for the nutrition in order to not disturb the bioenergy distribution during the day. We don't need a lot of food in the night because we don't need calories.
Yeah.
But we need calories when we wake up.
Yep.
So the breakfast, strong, and the dinner, low calories. This is not respected. And so a risk for a lot of cardiovascular or metabolic complication arise even because you lose to follow the chronic nutrition, we can say chrononutrition in some way. This is a developing, but it's an old story, but must be.
Yeah. Well, I've learned a lot. I ate 2 dinners last night. Maybe that was my problem today. I couldn't wake up. And then my session this morning was much too early. So I have learned a lot. I love your research. I think it's really fascinating. So I think we're probably getting to the end of our time. So I want to thank Professor Cutolo for your expertise and your time and your education. And I hope you, the listeners, have enjoyed our discussion today and gained some insights into circadian rhythm and inflammation, and also things like diet and sleep and exercise, etc. So please don't forget to subscribe to the CSF on your favorite podcast app and visit the CSF site for free access to educational materials, including summary slides, author interviews, and a monthly podcast hosted by the CSF chairman and EULAR President, Professor Ian McInnes. Thank you very much and have a great day.